M stands for masses and myocardial contractility. P stands for pleural effusions and pericardial effusions. And E stands for endocarditis and ectopic pregnancy. L stands for Lin-Weins DV. So that will explain whether you have any problem that is attributable to the pump. That means you are looking at the valves, you are looking at the myocardial contractility, you are looking at the pericardium and say whether there is a pericardial collection, tamponade is causing this kind of a problem. And you are also looking at the RV to LV size and profiling of the interventricular septum to say whether there is an obstructive component to the shock of this patient. So this in about 2 minutes time will give you whether the pump is actually good enough to work if the tank is full and the pipes are not leaking.
No,
Dr. Ravi,
about
the tank.
Finally, sure.
The tank will keep it brief. All you should look for is the collapsibility. Are the walls kissing on the IVC? And if you want to do, you can do the jugular vein as well. But the two things important is the patient intubated? Is the patient spontaneously breathing? That is the one thing you have to be careful of. And when you look at IVC, you have to look at the junction of RA where it joins the IVC. Otherwise, you can get a false positive. You have to be very careful of that.
You're fine. Now you finish.
Okay. So we come to the final this thing. So based on this hemodynamic evaluation, the patient was aggressively resuscitated. What happened to this patient? And then we'll put a final question to the panelists. And a periodic ultrasound evaluation demonstrated that IVC filling with volume loading, and he was started with broad spectrum antibiotic. In view of effusion, fever and shock, he was started with DVT prophylaxis also in large effusion, 300 ml. It was drained, and then his blood pressure improved with resuscitation, and then blood testing of troponin and all aortic evaluation are done, and finally the patient was discharged. But the final question which remains is that, is this ultrasound method is going to replace the invasive method of evaluating and managing the patients of shock? So I put this question to the panelists. One of you can answer and then we'll finish.
I'll ask Dr.
Yes.
I think this is the future. Soon echoscopes will be replacing stethoscope. It is much easier, non-invasive, and quite quick to come to conclusion. But a word of caution, like I'm sure one of us are formally trained in ultrasound, and radiologists are also not actually trained to interpret the things in this manner. They have been trained to do radiology for different reasons. So we need a lot of practice in this to come to a conclusion. I would say clinical examination, clinical suspicion supported by a proper ultrasound, focused ultrasound would be the future. This is my view on it.
Very quickly, gracefully for everything, we want to become less and less non-invasive. Even yesterday, I was talking to Parin, and he surprised me with one dictum. Nowadays, for sepsis, in place of Noradine, they are using more and more early patient 6 hourly, 4 hourly. They should not have to put central line. That was a finding for me, just after anecdotal statement. So, what I want to say, yes, it's a quick, within 30 seconds, you know what kind of shock you are dealing. Probably, if you are trained better way, you are not going to over-resuscitate the patient while putting central line, putting introduction, giving complication to the central line in some time is there. So yes, central line may be used more for the giving inotrope or vasopressor support rather than monitoring. Coming time, probably I feel like in my practice, probably since very long, I never measure CVP. We put arterial line once things are settled, not immediately once shock is settled. So ultrasound gives me a lot of information and it takes me to near accuracy. I'm not saying full accuracy. We need to learn a lot it, but whatever we have practiced in last 3 or 4 years since it has developed, it has taken me to near accuracy for diagnosing and treating the things.
Actually, CVP, the fallacies with CVP also can be sorted out by this. CVP can be high for so many reasons. And measuring CVP after insertion 2 to 3 days later, CVP actually gives false answers. So we should now not depend on CVP measurement. CVP should be used, central line should be used as a line rather than measuring the volumes. If it is there, you can still. But primarily, I think we should go by other methods to This is the volume.
Dr. Ravi, want to say something?
I'll come in and then wrap up.
Excellent case, by the way, Pradeep. Just a word of caution, do not replace art of medicine with the technology of medicine, is my view.
Obviously.
Yes, it has a place, but you cannot take away the art of clinical skills, I think.
So final figure from audience, what the audience feel? This is going to replace the invasive modalities of diagnosis. Yes, Dr. Dhruv. Yes.
See, first and foremost, I will endorse what Ravi has said. Please don't become technicians. Art of medicine has to be practiced, one. And secondly, the fallacies of CP which have been encountering are same the fallacies you can see with ultrasonography also. We have published that.
Thank you very much.
I'll give you a perspective on using diuretics in acute heart failure. I'd like to start off by thanking Dr. Mishra for inviting me. I have lost my voice in the last 2 or 3 days, mainly because I've visited 5 intensive care units in Ahmedabad. I've had lots of healthy discussions with a lot of very well-knowledge intensive care doctors. Unfortunately, I've done too much talking and this is the result. So my topic is using diuretics in acute heart failure. I'll start off with 2 definitions. One is acute heart failure, which is a rapid onset of signs and symptoms of heart failure. Rapid being the key word here. And another concept is acute decompensated heart failure. And this is often used as well. And what this means is that a lot of patients that present with acute heart failure actually have no chronic heart disease, but prior to presentation they were asymptomatic. So they had chronic heart disease, and then further ischemia has led them to become more symptomatic and go into acute heart failure. So the majority of the patients are of ischemia or infarction, 60 to 70%. Of course there are other reasons, but mitral regurg, arrhythmias, but 60 to 70% result from either chronic or acute ischemia. So what are the guidelines? How do we manage acute heart failure? In the West, we're very protocolized and we seek evidence, seek guidelines. So the first thing I want to present is the European guidelines of consensus from 2012, looking at all the evidence that there is. And one of the first things I say is class 1 evidence that intravenous loop diuretics are what should be given in acute heart failure. The level of this means that the risks outweigh the benefits, and the level of evidence is a B. So that means that there is a randomized controlled trial to suggest that this is a good thing to do. I looked further into it, and actually there isn't a randomized controlled trial. This was the trial that they quoted, and in fact all it says is that when you compare an infusion of diuretics against boluses, then there is no difference in outcome. So actually there is no evidence for it, as Dr. Haley I'm sure will point out. However, this brings us to the next key thing, is that we will never be able to do a trial with placebo versus furosemide. We will never get it past an ethics committee. That is just not going to be acceptable. So we have to accept what is based on our previous experience, what is based on our clinical skills and what we have done historically. So the day I left UK, Article 50 was triggered. We have declared independence, as it were. So now I'm going to have to stick to UK guidelines in the future. So UK, the National Institute of Clinical Excellence, again, is a sort of summary slide of what they suggest. And again, using intravenous diuretics is key. It does say consider giving CPAP, it does say consider giving inotrope, and consider giving GTM. Intravenous diuretics, key to management. So where am I going to get the crazy idea of not giving diuretics? These days in the land of Trump, that's where I looked, but this was pre-Trump. So in 2013, again, what are the guidelines from America? Well, once again, it is using intravenous diuretics. And if intravenous diuretics, one dose doesn't work, what do? You give some more. And this is what we're trying to treat. This is a congested heart. This is an X-ray. We've seen some great pictures on ultrasound from Dr. Krishraf. So yeah, whatever modality we use, this is what we're trying to treat, a congested heart, congested lungs. And this brings us to the Sprang-Stern curve. So what we're trying to treat is the patients to the right, where they are over the curve. They have got very stretched ventricles, and they need offloading. How do we offload them? Two mechanisms. One, we venodilate them, and secondly, we diurese them. Now, diuretics, look, they're a controversy, okay? It's been recognised that since the last 10-15 years, there are benefits and perils of using diuretics. But when do we use diuretics, and generally, what proportion will we do good with diuretics, and what proportion will we do harm with diuretics? This is a good study from many years ago, looking at about 500 patients that came in, I think it's to New York Hospital. And if we look at the spread of patients, we have congested patients and we have patients that have got poor perfusion. The majority of patients have congestions. These patients will benefit from diuretics. A minority do not have congestion due to heart failure. They are dry and they are peripherally cold. They may get harm from diuretics, but look at the numbers, 16 out of about 500. So this brings us to why. Why is there a difference? Why does furosemide sometimes cause harm, and why does furosemide, in general, most of the time, beneficial? I say furosemide because that is the diuretic, the IV diuretic that we use, and I think it's the one that most of the world uses. So, what we know clinically from our experience, not from trials, is that when we give intravenous IV furosemide, suddenly there is a rapid fall in the right heart filling pressures before any diuresis occurs. So we give the diuretic, and within 5 minutes you'll have symptomatic relief. The diuresis occurs a good 1 hour, 2 hours later, so you're getting an immediate venodilatation. The mechanism of this is quite important to understand. So essentially it's related to the furosemide-mediated renin release, which stimulates production of angiotensin 1 and angiotensin 2. We know that angiotensin 1 is a vasoconstrictor, but there is also simultaneous angiotensin 2 related release of prostaglandins, which venodilate, and it's the venodilation which is the overall effect of the furosemide. So what is happening in the non-congested patients? Well, in the non-congested patients, where the small minority may get harm from furosemide, it may cause, contradictory, a slight rise in systemic and pulmonary vascular resistance. And the hypothesis, this has not been proven, is that these patients have chronic heart failure, they already have very high levels of angiotensin 2, and as a result, they have already a maximally increased venous capacitance dilatation. So then increasing further angiotensin 2 actually causes more vasoconstriction. So the opposite of what happens in the majority of patients. This is a minority of patients. So what is our current practice? Well, look, loop diuretics, 90% of us hospitalized with acute heart failure, we would give loop diuretics to. One of the Indian guidelines was the Indian practice. This is a nice study from Ames and Dundee, where again practice